Good afternoon, everyone, and thank you for joining us for today's webinar. We are going to get started here in just about 10 minutes, but before we do, I would like to go over a few housekeeping items with those of you that have already joined us. For those of you that we do have in the room, the first thing I would like to make mention of is the chat pod, which is located on the left-hand side of your screen marked chat. This chat pod will be the best way to communicate with us today. Should you have any questions regarding today's material, all questions pertaining to the material will be retained until the Q&A session that will be held after all of our presenters are finished. We do have 4 subject matter experts and presenters today, so please feel free at any point of any presentation to go ahead and type in your questions there in the chat pod, and we will pull them out and hold them for you, and then again get them asked at the very end of today's webinar. This chat pod is also the best way to communicate with us should you experience any technical issues. If you do have any technical issues, please make sure to let us know there in the chat pod, and either myself or one of our customer service representatives will make sure to get you taken care of. All of your audio for today's webinar is going to be streaming through your computer speakers, so if at any point during today's live webinar you do either lose your live audio or live video feed, the first thing we would like for you to do to troubleshoot is simply refresh your web browser and then hit the play button again on your live video window. This should refresh your connection and get you back on your live audio and video feed. But if for some reason this does not work or you experience any other technical issues, again, let us know in the chat pod and we'll be sure to get you taken care of. Or also above the live feed window, we do have our toll-free number as well as our email address should you want to reach out to us that way. Also below the live feed, you will notice that we have our closed captioning pod. Once we get started with today's event, those closed captions will be rolling in real time. So if you would like to follow along there, please feel free to do so. Just as with all of our other webinars, we do like to find a little bit more about our audience before we do get started. We do have a few of you that have already typed in your location, but those of you that have not, if you could please take a few moments before we do get started to just type in your location there in the chat pod. That'll give myself as well as our presenters some great feedback about where the audience is joining us from today and just what kind of reach we were able to obtain with today's event. We've got about 6 or 7 minutes before we get started, so I'll mute my line back for now, and then we will get started here at the top of the hour with today's event. Thank you for joining us. Good afternoon, everyone, and thank you for joining us for today's webinar. We are going to get started here in just a few minutes, but before we do, I would like to go over a few housekeeping items with those of you that have joined us in the room so far. For those of you that we do already have in the room, the first thing I would like to make mention of is our chat pod, which is located on the left-hand side of your screen marked chat. This chat pod will be the best way to communicate with us if you have any questions regarding today's material. All questions pertaining to the material will be retained until the Q&A session that will be held at the very end of today's webinar. We do have 4 presenters for today's event, so please feel free at any point of any of the discussions today to go ahead and type in your questions there in the chat pod, and we will pull them out and house them for you, and then we'll get them answered during our Q&A session that will be held at the very end of today's event. This chat pod is also the best way to communicate with us should you experience any technical issues. If you do have any technical issues, please let us know there in the chat pod, and either myself or one of our customer service representatives will make sure to get you taken care of. For today's webinar, all of your audio will be streaming through your computer speakers. So if at any point of today's live event you either lose your live audio or your live video feed, the first thing we would like for you to do is simply refresh your web browser and then simply hit the play button again in the live feed window. This should refresh your connection and bring your live audio and video feed back up and running. We also suggest that you utilize either Mozilla Firefox or Google Chrome as your web browser to view today's event, as those two seem to give the best user experience for our webinars. If for some reason your live feed or audio is still not working, or you are experiencing any other technical issues, again, you can let us know in the chat, or you can utilize the toll-free number and the email address that are located directly above the live feed window. You'll also notice below the live feed window, we currently have our closed captions that are going to be running throughout today's event. So if you would like to follow along there, please feel free to do so. It is the top of the hour, so we are going to get started here momentarily, but before we do, we always ask our audience to go ahead and type in your location there in the chat pod. This provides some great feedback about the audience members that are attending today's event and where you are located throughout today's world. Again, it is the top of the hour. I'm going to mute my line back for now. I'll switch some things around on my end, and then we will get started momentarily. Thank you for joining us today. Good afternoon, everyone, and thank you for joining us for today's webinar. My name is Josh Vickers, and I am with RTI International's Forensic Technology Center of Excellence. Today's webinar is a part of our webinar series on opioids and emerging drug threats, integrating public safety and health data for a forensic response. Our topic for today is forensic epidemiology, monitoring fatal drug overdose trends. We do have four presenters today: Dr. Sarah Lathrop, Rosie Hoburn, Allison Miller, and Justin Brower. Our first presenter of the day is Dr. Sarah Lathrop. She received her undergraduate education at Colorado State University and then earned her DVM from the University of Minnesota College of Veterinary Medicine. She practiced veterinary medicine in Cortez, Colorado, and then completed a PhD in veterinary preventative medicine at Ohio State University. Dr. Lathrop served a 2-year postdoctoral fellowship at the Centers for Disease Control and Prevention as an epidemic intelligence service officer studying vector-borne infectious diseases. She joined OMI in 2003 to conduct epidemiological studies using medical examiner data. She also serves as the principal investigator for the FoodNet portion of New Mexico's Emerging Infections Program. Her research interests include the intersection of forensic pathology and epidemiology, public health topics such as trends in violent deaths and certain unexpected infant death investigation, as well as investigation of foodborne infections. Just our quick disclaimer: the opinions, findings, and conclusions or recommendations expressed in this presentation are those of the presenter and do not necessarily reflect those of the Department of Justice. Any products and manufacturers discussed are presented for informational purposes only and do not constitute product approval or endorsement by the U.S. Department of Justice. And now, without any further ado, I would like to hand the microphone and platform to our very first speaker of the day, Dr. Sarah Lathrop. Dr. Lathrop?
Thank you, Josh. And I'd like to thank the organizers for inviting me to present today. I've been the epidemiologist here at the New Mexico Office of the Medical Investigator since 2003, and unfortunately, we've had a lot of experience with unintentional overdose deaths during that time. And so I'd like to share with you a little bit of what we've learned during that time. Sorry about that. Here we go. So to do that, I want to give you an overview, a little bit about New Mexico and how medical legal death investigation is conducted here, and then what we've developed as a triage system for assessing potential overdose deaths developed over time as we've been dealing with these, and then what we've learned from developing that tox data and what the trends in overdose deaths in New Mexico have been over the last 20 years. I also want to share with you some special studies of opioid overdoses that we've done here and encourage you to tailor some studies for your own jurisdictions to better understand what's actually going on there and how best to prevent these types of deaths. If nothing else, I'd like you to remember the importance of partnerships and collaboration. That's really what it's been about as far as making effective use of the tremendous amount of medical legal death investigation that's collected by forensic pathologists, by death scene investigators, by medical examiners and coroners, and really trying to maximize the utility for the good of that data. So a little bit about New Mexico. A lot of people have not been out here. To the laser pointer. We are a very large state. We are the 5th largest state geographically. We have 33 counties. The Office of the Medical Investigator is located in Albuquerque, here in the heart of Bernalillo County, right in the center of the state. So we have a network of transporters who will bring bodies in from those outlying counties if our field investigators who live and work in those counties work with our central office and determine that those bodies need to be brought into our Albuquerque facility for a full autopsy, or if they can be left in the county and have a field external exam done. We have only 2.1 million people as of 2018, so very few people in a very large geographic area. Our population is 49.1% Hispanic, almost 11% American Indian. There are 23 American Indian tribes in New Mexico, and that's 19 Pueblos, 3 Apache tribes in the Navajo Nation. In the lower right-hand corner there is a picture of Taos Pueblo. It's an amazingly beautiful World Heritage Site in the northern part of the state. So when you inevitably plan your trip to New Mexico, I'd encourage you to visit Taos and Taos Pueblo. So how do we investigate deaths here? We are a statewide centralized medical examiner agency. So we bring those bodies in as needed in consultation with our central office investigators and forensic pathologists. We have state authority to investigate any death in the state which is untimely, suspicious, violent, unattended by a physician, with the exception of federal lands, military land, and tribal lands. We don't have jurisdiction there, but very often we are hired on a consultation basis in order to conduct autopsies for the investigative authorities on that land. We currently have 8 board-certified forensic pathologists working here. They conduct about 2,000 autopsies per year and then play some type of investigative role in about 1/3 of the 15,000 deaths that occur in New Mexico each year. We've developed standard operating guidelines over time, and it's always a work in progress to try and best use our resources, make the best use of the forensic pathologist time, but still get the data and the information that we need for certification of cause and manner of death, as well as understanding the larger trends that are going on. So based on history and scene investigation, we will work with our investigators to determine if a potential drug overdose death needs to come into the central office. And that's based on scene photos like you see here. I'm sure you're all familiar with this type of paraphernalia being found on scene and raising that index of suspicion that this is a potential overdose death. We do have an unusual luxury here, and that is postmortem computed tomography, PMCT. That is performed on every decedent that comes into the office, and that way we can rule out trauma, we can identify any natural disease that is present in that decedent, and then we can look for the triad of findings that we would expect to see with a potential overdose death, and that includes cerebral edema, pulmonary edema, and dilated bladder. So using those CT results, since last May, we've also been incorporating a urine drug screen to try and triage these cases most effectively. If those urine drug screens come up positive, we will send specimens to NMS labs for confirmatory tox testing. Using the CT findings, the scene investigation data, and then the urine drug screen, we can classify these deaths into one of 5 categories for how to proceed. If the decedent was young and healthy and the urine drug screen is positive, we will send in confirmatory tox testing and do an external exam. But if it comes up negative, we will move to a full autopsy. If the CT shows significant natural disease, that most likely will be an external exam and the urine drug screen. Overwhelmingly lethal disease, we'll use the urinary drug screen to determine if tox testing is needed and send on to NMS as needed. If we suspect acute versus chronic ethanolism and alcohol exposure, most likely that would revert to an external exam and tox testing as well. Of course, if it's a suspected suicide or other types of exposures, we will do the full autopsy. So what have we learned from all that tox testing over the years? Well, you can see that consistently, New Mexico has had higher drug overdose death rates than the United States. The United States here in turquoise, New Mexico in orange. It's sort of quaint going back to 1990, and the rate for the U.S. then for unintentional drug overdose deaths was 3.4 per 100,000. New Mexico was still more than double that at 7.7, but compared to what we're seeing today, that seems very, very low. And we've seen a steady increase, not just in New Mexico, but across the United States. I don't think that's a surprise to anyone. We're still higher here in New Mexico as of 2018 at 26.6 deaths per 100,000 compared to 21.7 in the U.S. For many of those years, New Mexico would vie for the title of #1 or #2 in the country for unintentional drug overdose death rates on a per capita basis, and we have dropped to 14. And unfortunately, that is because other states have caught up to us with the prescription opioid epidemic. We're really seeing a lot of higher rates in states where it wasn't nearly as high back in the 90s and the early 2000s. And I would like to, as part of acknowledging our collaboration, thank Jim Davis, the outstanding substance abuse epidemiologist at the New Mexico Department of Health, for sharing this figure. And we're very fortunate to have a longstanding collaboration with our partners at the Department of Health. Not only can we track those basic trends and how they just keep climbing, we can really break it down by drug category so we know what's impacting our population. And this is information that we can then share with the Drug Enforcement Agency, other agencies that are interested in knowing what's actually killing people at any point in time. And you can see this is going from 2012 through 2018. These non-fentanyl prescription opioids are certainly having an impact, but you can't ignore everything else that we're also seeing. Fentanyl has been climbing steadily over these 6 years. We didn't see the impact quite as quickly in New Mexico as states on either coast did, but we're certainly very aware of it and keep testing for it because it does seem to be increasing within the state. We have an ongoing challenge with heroin. We can't ignore that just because of what the goals that we're seeing of the prescription opioids. We're also seeing uptick in methamphetamine. Certainly since I began, it's taken on a much larger contributory role as far as causing deaths. And then being aware of the synergistic role of benzodiazepines in this as well. Back in 2003, we would see 1 or 2 substances on the tox results, and now we're seeing a lot more polypharmacy. You almost have to be a board-certified toxicologist to figure out how all of these substances that are found in a single decedent are contributing to the cause of death. So we're fortunate to have very good forensic pathologists here who work closely with the toxicologists at NMS and SLD to try and figure out what's actually going on as far as the cause of death. We can also break the drug overdose deaths out by county. You can see, if you keep in mind that the U.S. rate currently is 21.7 deaths per 100,000, more than half of the New Mexico counties are higher than that, some of them significantly so. Rio Arriba County here at the very end with the highest at 92.8 deaths per 100,000 population has traditionally been the highest per capita county in the United States for unintentional drug overdose deaths. Traditionally, that's been problems with heroin, challenges with heroin, but of course we're seeing the impact of prescription opioids there as well. So we also want to understand what's going on across age categories by sex and drug type as well. This is something that everyone is interested in, and it certainly shifts the paradigm from the early 2000s when I started, and this was thought to be a problem. Overdoses happen among young men. You can see from this data, it does not discriminate. It's impacting males and females. It's across all age categories. The breakdown here in the orange is prescription opioids only. Heroin is certainly still significantly contributing to these deaths in the turquoise bars, And then these gray bars are the ones where we're finding both, and some usually more than just opioids and heroin as well, and across all ages. You can't assume anymore that this is a problem just among men. We're certainly seeing the impact in our female population as well. And you also can't assume anymore that, oh, somebody's 60 or older, it's probably not an overdose, it's probably natural disease. We're certainly seeing these deaths among older folks as well. So just a little bit about what an epidemiologist can do for you, even if you don't have one in your office, if you get to know somebody at your local health department, or the DEA has excellent analysts who would love to see your data. So you can do that ongoing surveillance across drug category, age, and gender to know what the impacts are, but also to dig a little deeper for research questions that have evolved probably very organically from your own jurisdiction. And that's what we found is a lot of these good research questions come from our investigators. They come from our forensic pathologists from what they're seeing at the scene or in the autopsy suite, and it raises questions about why am I seeing people with multiple fentanyl pain patches on? What is going on with that? And so these are just 3 recent examples of some epidemiologic research that we've done here. The first one is scene findings associated with unintentional overdose by age. We had one of our outstanding field investigators suspect that we were missing some overdose deaths among older folks, and were there markers of things occurring at the scene that we could use to point us towards the tox testing for those older decedents. We also did a study with a medical student last year looking at unintentional overdose among women. This tends to be an overlooked population. She wanted to get a better understanding of how this was impacting women in the state of New Mexico. And lastly, just a brief sharing of information from our NIJ-funded comparison of autopsy and CT findings. We did 4 different cohorts comparing autopsy and CT findings to see if either modality was missing significant findings. One of those cohorts was a cohort of 457 drug overdose deaths, and what we've learned from that toxicology cohort. So just a little bit on each of those studies. We had an investigator working here for a number of years, Tim Dubois, and he felt that we may have been missing some drug overdose deaths among older people. Again, because we do, it's human nature. You know how to operate. If somebody is older and they're found down at home and it looks peaceful, it's probably natural disease, which often is a fair assumption, but no longer can we overlook the fact that it might be a prescription opioid overdose. And so we worked together to review the literature and look at certain scene markers, things like scene scrubbing. Did somebody come in and remove paraphernalia and clean up the scene before law enforcement and investigators arrived? Was there drug paraphernalia on scene? Was there evidence of alcohol use at the scene? Did the decedent have a history of depression? Were they released from jail within the past month? All indicators with the jail within the last month, that's a high risk for overdose deaths. What could we use to raise the index of suspicion that this is an overdose death among people 50 and over? And certainly we found a significantly higher prevalence of natural disease in those older folks, but we did find some of those scene markers that would help us perform the confirmatory tox testing that we may have overlooked previously. And Mr. Dubois presented this at the AFS meeting back in 2015. Last year, Elena Gandera, a 4th-year medical student here, worked with us doing a deeper dive on when women die of overdoses here in New Mexico, what is contributing to that by reviewing the cause of death statement. And you can see the outsized role that all opiates have. Prescription opioids at 43.8%, but then here's heroin at 15.5%. Here's our synthetic opioids playing a role at 11.7% of these deaths. And then fentanyl down here at 4.9%. So when you take that in total, really trying to understand the role of opioids in causing deaths and really the increase among women dying from these types of overdoses without neglecting to pay attention to things like benzodiazepam and methamphetamine and the polypharmacy too, seeing multiple drugs in single decedents. And our last study that I'll share with you here is just a little sample from our NIJ study of postmortem CT supplanting or supplementing medico-legal autopsies. And what we wanted to know with these drug overdose deaths was if you only had CT findings, could you still come up with an accurate cause of death as compared to full autopsy? And for people under 40, 86% of the time you could. It was pretty good. A little bit trickier when you get over 40. Only 75% were a match for that. But there were many instances where you could use those CT findings to correctly call cause of death with the scene findings and the toxicology findings. So in all of this, the key to informing prevention and control measures is really collaboration. you do a tremendous job collecting all of this medical legal death investigation, not just with overdose deaths, but with a lot of deaths that are of public health significance. People want that data. Epidemiologists love data. So get to know your local health department, perhaps the local school of public health. I did not know that we were part of a high-intensity drug trafficking area and that we had an office here right in Albuquerque, not far from us, until one of their analysts reached out to me for data. And since then, we've been collaborating with them, sharing data, and working together on an opioid coordination group, which has been very helpful. And it's certainly mutually beneficial. They share with us information on what they're finding on their seizures, what the trends are across the United States, and what we need to be aware of as we're going on scene investigations so that we have the latest information that they're working with as well. I say, get to know your epidemiologist and start sharing this data. There's so much good you can do with it, but a word of caution, please check with your legal counsel to determine how much of your data you can share. There's protected health information in there. This varies widely by jurisdiction. Here in New Mexico, we are a Public Records Act state, so we can be asked to provide a lot of personal details about our decedents. That is not the case everywhere. Other states have a 50-year moratorium on sharing that type of data. So just before you get too excited about doing epi studies and bringing in analysts, make sure you're on sound legal footing so that you don't get into trouble. And also to let your partners know that timeliness can be a little bit of a challenge. It takes some time to synthesize all of the tox results with the rest of the scene and autopsy findings and get to that final cause of death. And so it may not be quite as real time as they would like to see. We pull our data of all pending and completed overdose deaths quarterly and share that with both the health department and the DEA. And that seems to be working well, but ideally, it would be a little closer to real time. But again, with resources being what they are, we do the best we can. So with that, I'd like to summarize. Unfortunately, we've had decades of experience with high rates of unintentional drug overdose deaths here in New Mexico. We've developed a triage system that's in place using a urine drug screen, CT, and a combination of autopsy and external exams. Again, trying to make the best use of our resources. We're always limited as far as funding for tox, funding for full-time equivalent forensic pathologists. How can we do the best job possible, get as much useful information, correctly certify those deaths, but still make good use of the resources that are limited but that we do have available? If you can find an epidemiologist, not every office has one, but you may have a school of public health or a DEA analyst or a health department analyst. They would love to see your data and provide that baseline surveillance so that you know what drugs are impacting what population, what the risk factors are. They can also help a lot with data requests. I was talking to the other epidemiologist that will be presenting next, and a lot of our time is spent fulfilling data requests. So hopefully somebody could help you with that because it can be very burdensome, but you want to get that data out there and share as much as possible. And then hopefully be able to do some special studies that are tailored to your jurisdiction to better understand what's going on there. Again, the key takeaway is the partnerships with other agencies, your local health department, the DEA, anyone who might be interested in doing the outreach, because I feel working in a medical examiner office all these years, I feel like we're really good at collecting the data. We've got a tremendous amount of really good data. We can analyze that, we can publish it in the papers, we can get it out to national meetings, but as far as doing community outreach and community-based interventions, that's where you need your health department, that's where you need community partners who have those types of skill sets, which I don't feel like personally I have. And so it's really great to be able to work with agencies that have that type of skill set. That way, you're able to maximize the utility of all of this incredible overdose investigation data that you all work so hard to collect, and hopefully use that to prevent additional overdoses as we try and figure out how to bring an end to this, especially the prescription opioid epidemic that we're seeing. With that, I'd like to thank you for your attention and point you towards our annual reports. We have data going back to 2000. Those reports are organized by manner of death, but there are also sections on drug-caused deaths. So if you're really interested in that, you can go to our website and spend hours browsing through those annual reports. And with that, thank you very much, and I'll turn it back to Josh.
All right, thank you so much, Sarah. I am going to go ahead and take over control of the screen again so that we can introduce our next presenter. But before we do, I do want to make all of our participants aware that we will be providing a PDF version of all of the presentations for today's event. So once we are finished with today's webinar, you will be able to go back to our main page and download any of today's presentations. All right. So our next presenter is going to be Rosie Hoburn. She graduated with her undergraduate and Masters of Public Health in Epidemiology degrees from the University of Nevada, Reno. She previously worked at the Nevada State Health Division as a communicable disease epidemiologist. She moved to Virginia in October of 2013 for a position in the, one second while my computer comes back up, I apologize, for a position at the Chief Medical Examiner, OCME, of the state of Virginia. And with that, I'm going to go ahead and hand things over to our second presenter of the day, Ms. Rosie Hoburn.
Great, thanks, Josh. Get this set up really quick. Okay, today I'm going to be speaking about the drug crisis here in Virginia, the forensic epidemiology that goes on in my office and how these kind of intersect, and talk about death's role in public health and prevention. Here in Virginia, we are a statewide medical examiner's office. We have 4 offices statewide that is broken up by geographic distribution. We have our state office that oversees our 4 district offices, and it's co-located in our Richmond office in the central region. Just like the last presenter discussed, not every death that occurs in the state of Virginia becomes a medical examiner case. Here's the criteria of what kind of circumstances need to happen to become or to fall under jurisdiction of the OCME. First off, that the death must have occurred in Virginia. We have a lot of out-of-state residents. Best example are people, driving from, point A to point B and then getting a collision. So we take those cases. And then it's really anything that is an unnatural death, meaning accidents, homicides, suicides undetermined, violence, suspicious, anything that's unnatural. And then we also take custody of anybody who dies while in a state facility, whether that be a jail, a prison, or a mental health facility across the state. So for context, this represents the black line up top represents the total number of deaths that occurred in Virginia by year. In 2018, it was almost 70,000 deaths that occurred statewide. But of those, we only took jurisdiction of roughly 10% of those cases. And then of that, about 7% are certified as unnatural causes of death, so accidents, homicides, suicides, or undetermined. And obviously through the death investigation process, we generate a lot of data, we get a lot of reports, and a lot of information is collected. So we have a lot of data on deaths that we investigate. And so we have kind of 2 sources of data. There's me that does kind of the forensic epi side, and then we have our surveillance and fatality review program, and it has multiple programs underneath that group. And so for the forensic epi side of what I do, I look at all cases that fall under OCME jurisdiction. We look at things based on deaths that occur in Virginia, because we obviously partner with law enforcement for all other investigations. We report on very recent data. I'm going to talk later for the drug deaths specifically. We can release up to the past quarter on cases that have been finalized. However, we're pretty restricted on the details that are collected during a death investigation. We don't have a very comprehensive database like I'm going to talk about in our surveillance and fatality review. They're a little bit behind, roughly 2 years behind, and that's mainly because they have a lot of data abstractors that review the files and enter very specific case information into a large database that usually goes to the CDC. And for context, I'm not going to really talk about these programs, but there is a difference between surveillance projects. Those are nationally, typically CDC-funded grant projects, and then we have state fatality review teams, which are state-funded. The main difference is surveillance projects. Those are the case reviews. They look at all a specific type of cases. They abstract the information, put it into a database, and that goes up to the CDC. whereas fatality review teams, they are a diverse group of stakeholders across the state that come together and review a specific type of cases, for example, child drownings, and they will look at circumstances of around the death and what happened and make recommendations as a team about how to prevent these types of deaths in the future. And so as we talk about specifically about fatal drug overdoses, here in Virginia, we do have myself, which is an in-house epidemiologist that works with the data that's generated here. I know that other states use vital records data, and that stuff is obtained from death certificates that are filed with the Electronic Death Record System, EDRS. And so here in Virginia, we have an internal coding schema. We don't use an ICD-10 codes. And we code all of we code individual drugs using toxicology results as well as cause of death statements. Vital records just uses cause of death statements. And we report on location of events, so in this circumstance, where the event occurred, which would be an overdose. And then vital records uses location of residence to determine what cases are theirs, and then they pass those out of state if the person's not a resident of Virginia. And again, we do quarterly reporting. Obviously, some of these cases, specifically our drug overdose cases, can take a little bit longer, so they'll be pending for a little while and take more than the average turnaround time, which is about 2 to 3 months. But we do quarterly reporting, but vital records data can be up to a year or even more of a delay. And just for clarification, all of our toxicology testing occurs at the Department of Forensic Science, which is a separate state agency from the OCME, who falls under the Virginia Department of Health. But they do all of our toxicology testing, anything on the forensic side that doesn't involve the body, so anything evidence, ballistics, blood, DNA, drugs, and toxicology testing. So just to make that clarification. And then looking at the data that's generated here in Virginia, this graph represents the top 3 methods of unnatural death, and this includes all manners, again, accident, homicide, suicide, and undetermined. And these are the 3 leading methods here in Virginia, as well as nationally. In blue, you can see that these are motor vehicle-related deaths. In the gold yellow line are all of our gun-related deaths. And then in pink are the fatal drug overdoses. As you can see, in 2013, fatal drug overdose became the leading method of unnatural death in the state, and has just increased significantly since then, mainly driven by the opioid crisis and very specifically illicit fentanyl. And again, all the coding here that we do is based on individual drugs themselves, code for up to 60, 70 individual drugs themselves, as well as multiple fentanyl analogs, just a variety of things. So anything that caused or contributed to the death is coded. And as you can see, looking at specifically opioids here, you can see that it counts the number of times that these drugs were involved in an overdose death. Obviously, these are not mutually exclusive categories because, as the previous speaker stated, we do see a large variety of deaths that have multiple substances causing death. And you can see that oxycodone for the longest time, 2007 to 2014 or so, that was the leading opioid that was killing or that was involved in most overdoses, but the landscape has really changed with the introduction of illicit fentanyl. And then being able to identify the individual drugs themselves, you can make your own groupings. And so what we do here is the black line represents any fatal overdose that involved any type of opioid, whether that's a prescription, illicit, or both. You can see that's been increasing, but then we can stratify those two and look at prescription opioids excluding fentanyl only, and that's in the blue line. But then we could also group the fentanyl and heroines together, which is in pink, and that's because a lot of the heroin out there is being cut with fentanyl or being replaced with fentanyl, and so users don't really necessarily know what they're getting. And you can see that here in Virginia, the fentanyl and heroin has been increasing significantly since 2015. And again, by using our database, we've been able to geolocate events of overdoses. So these are where decedents overdosed, and then coded over what type of drugs were involved. So the red involves illicit opioids, and the blue involves prescription opioids. And just to give you a quick rundown of Virginia, the western part of the left part of Virginia is part of the Appalachian region. It's very rural, very sparsely populated, low access to health care, and high rates of poverty, whereas on the other side of Virginia, the right side where all the other dots are, it's much more urbanized, higher populations. It's the metropolitan areas of Virginia. And what you see when you do these geolocated drop pins, you can see that for most of our prescription opioid deaths were at our western part of the state, which is our rural area, and the red dots, which represent the illicit opioids, those were found much more so in the urban metropolitan areas, Washington, D.C., central Richmond, and the Norfolk, Virginia Beach area. Yeah, so right here, prescription and illicit. And we can't have an opioid discussion without talking about fentanyl. Fentanyl was introduced in Virginia in late 2013, early 2014. We started seeing a lot of IV heroin users test positive for fentanyl, so that was kind of something going on. And then it's just been a significant rise since then. 2016 was a really terrible year for us. We have an increase of almost 180% in the number of fentanyl deaths from the previous year in 2015. And it's just grown since then. The various fentanyl analogs that have been introduced in the state, this represents the number of deaths by quarter. You can see that there are a variety of different analogs that have, more or less potency. You can see those kind of come in waves, and we'll see a spike in them, and then they'll go away. And that was hard at the beginning of all the crisis, and when these were getting introduced, was having the labs stay on top of and being able to test all these. And then here's just a map, some data. You can see that fentanyl is really found in kind of our northern part of the state, and it's kind of starting to be found everywhere. But, the rates are hitting, multiple localities. And it's been, if you look at these maps over time, you can see that fentanyl is really starting to make its way out west. The bottom of the pie chart really just demonstrates the lethality of fentanyl and the various fentanyl analogs. The first pie chart on the left side represents the number of all drugs submitted to the Department of Forensic Science for drug testing. And so those are anything that's a law enforcement stop and they have, drugs on scene or whatever, and they confiscate those and submit those for testing for prosecution. That and fentanyl and various fentanyl analogs represented about 6% of their caseload for 2018, but in comparison, nearly 55% of all of our fatal overdoses in 2018 involved fentanyl or fentanyl analogs, which is shocking. And then also non-opioid drugs like cocaine and methamphetamine are also on the uptick. There's a couple reasons for that, but cocaine keeps showing up in a lot of our fatal overdoses. In 2018, of all of our cocaine overdoses, if you look at those specifically, 65% of those also had fentanyl or fentanyl analogs, and cocaine's really kind of found all over the state. And then looking at methamphetamine, we've been hearing a lot of stuff from the DEA that as we've been putting the stomp on opioids, the cartels are starting to traffic methamphetamine up through the border. And here in Virginia, we had several years ago, we really had a homegrown kind of meth lab issue where it's, the small, low quality amounts, but that's really kind of the landscape of that is really changing as methamphetamine is making its way up in here. And if you look at the map at the bottom, all of the areas with the highest rates of fatal meth overdoses are really a rural area. And then in 2018, 46% of all of our methamphetamine overdoses also had fentanyl causing death. And then just kind of to kind of bring everything together, we obviously generate a lot of data here, and death is the worst case scenario. It's the talking point. It leads the headlines because it's the worst case scenario. So we have a lot of people that come to us and want our information, whether that's to use for grant justifications, they want to do targeted interventions, or they want to do further research on, if the implementation of a new program has worked, or just to use for a variety of different things. We work with local law enforcement, state, federal, local agencies, and then we work a lot with the media. Collaboration is key, just like the last presenter said. So with that, I'll leave my contact information, and then there's just some links to our reports that we have online. I do a quarterly drug report with spreadsheets that people can download and kind of do some of their own analytics. We have annual reports, and then the surveillance and fatality review. That's a variety of all of our programs and the reports that are generated from there. So thank you. Thanks for my time.
All right, thank you so much, Rosie. We are going to go ahead and move to our last presenters of the day. I'm going to take back over control of the screen. Hopefully it will work a little bit better this time. So our next presenter is Ms. Allison Miller. She's an epidemiologist and grant manager for the North Carolina Office of the Chief Medical Examiner. She's responsible for tracking all deaths investigated by the medical examiner system in North Carolina and producing special reports intended to highlight emerging trends such as the rapid rise in deaths involving fentanyl analogs. Since starting in her position in February 2015, she has secured more than $2 million in equipment and staffing and worked collaboratively to publish research on deaths involving methoxylone, loperamide, gabapentin, fentanyl analogs, and other opioids. She earned her Master's of Arts from New York University, and she is currently in the Master's of Public Health program at Johns Hopkins University, where she is focused on issues relating to addiction and overdose as a Bloomberg Fellow. Assisting with her presentation today will be Dr. Justin Brower. He is a forensic toxicologist at the North Carolina Office of the Chief Medical Examiner and a clinical assistant professor in the Department of Pathology and Laboratory Medicine at the University of North Carolina School of Medicine. He earned his PhD in organic chemistry at the University of Nevada and followed with a postdoctoral appointment at the University of California, Irvine, with a fellowship from the Cancer Research Institute. In addition to certifying post-mortem toxicology cases at OCME, he develops LC-MS assays for routine and non-routine analysis, as well as targeted Orbitrap LC-MS screening analysis. And I'd like to hand the microphone and platform over to our last presenters of the day, Ms. Allison Miller and Dr. Justin Brower.
Hi, thank you all for being here. So Allison and I are tag teaming this presentation today. See if I can do this right. Oh no. Share. All right, I'm getting there. Bear with me. There we go. So Allison asked me to join this group to try to give a perspective from a forensic toxicologist rather than strictly from an epidemiologist standpoint, just kind of my perspective of the drugs and drug analysis and kind of what we're seeing at the laboratory level. So I'll talk for a little bit, and then Allison will take over at the end. So this is our lab in Raleigh, North Carolina. We have a centralized system where all the toxicology is done at a central laboratory in Raleigh, and autopsies around Raleigh, Durham area come here, and then we have several satellite facilities throughout the state. So we are a statewide medical examiner system, much like you heard from New Mexico and Virginia. And what makes a medical examiner case is really the same as those two states. Deaths that are unnatural, unwitnessed, involving children, obviously homicides, suicides, and also police custody or some sort of state custody. Those are all medical examiner cases. So On the toxicology side, we serve all 100 counties of North Carolina. I don't know what all they are. I don't know where they all are. I have a map in my office to keep track of them. But it's a lot of real estate in North Carolina. North Carolina has about 10.5 million people. But compared to, say, like New Mexico, we have like maybe 5 times the population, but we have about half of the land area. We're not a small state by any means, but it's not nearly as expansive as a state like New Mexico. We only do post-mortem work, so we don't do any DUI cases at all. And we handle about 12,000 cases a year, and of those, we do about 3,200 drug cases. So these are deaths that are thought to involve drugs, or we're doing toxicology to try to rule it out. We'll test anything that you can pull off a body. If it is attached or was attached at one point in time, we can analyze it. So we do blood and tissue like, liver and spleen, muscle. We've done, bone from skeletonized remains, physical evidence, you name it. We can test it. We've even done maggots before. It's not the analyst's favorite thing to do, is to grind up maggots, but you do what you got to do. All in all, it's just my fancy way of saying, we really do see it all. And that's one of the advantages of working at a statewide system. You have a huge population that you're dealing with, and you really do get to see everything, as opposed to, like say a smaller city system or a county or regional facility. We see 12,000 plus cases a year. And it's probably an epidemiologist's dream to have all that data to work with and sort through for, fancy graphs and charts and stuff like that. At OCME, we have 3 forensic toxicologists like myself that review and certify drug deaths, an evidence technician. All of it's got to be accessioned and barcoded, starting the chain of custody. So that's really one of our most important jobs, and that's all handled by one person, and she's fantastic. 10 various levels of forensic chemists, from a supervisor to our entry-level chem tech positions. And then we generate a lot of paper. We're not a paperless system yet. We're working on it. But we have 2 document specialists that help, get all the case folders together and kind of double check all the work and generate the reports. So on our drug-related deaths, we have several different screens, but in total, we're looking at 600 plus different compounds. These are all the standard, pharmaceutical prescription type drugs, but also our standard illicit drugs that we're all very familiar with, like cocaine and heroin and methamphetamine and fentanyl, but also like the next generation of illicit drugs. So these are all the fentanyl analogs, the novel opioids that we hear about, like U47700, and kind of that alphabet soup type nomenclature, as well as synthetic cannabinoids are coming onto the scene in a big way now, or at least in deaths. They've been around, but it's only recently with this last generation that are super potent and contributing to causes of death. And also the so-called like designer benzodiazepines. We're seeing more and more of those as well. And those are all things that we are on the lookout for, pay attention to, and incorporate into our screens. But over the last, 5-6 years or so, the magnitude and scope is increasing and changing. And you heard the other speakers talk about this a bit. 10 years ago, you'd have a death and it would just be, oxycodone and some alcohol, or, some Xanax and methadone, or just cocaine. But now we have so many more drugs involved in, the polypharmacy, so to speak, where our typical case might be heroin plus fentanyl plus cocaine plus methamphetamine plus some SSRIs because, they have some, anxiety and depression. So they're also on some benzodiazepines. And so you're not only screening for a lot more, but you're confirming a lot more drugs. And, so instead of doing 2 confirmatory tests, we might be doing 6 or 7 or 8, which puts a huge burden not only on our laboratory and the people, doing the analysis, but also our stakeholders as well, like epidemiologists. They're contending, with a large number of drugs in these cases that, they've got to flesh out how they're involved, but also the new drugs as well. It's one thing for me to understand what 2-ethylphenylfentanyl is, but trying to convey that to an epidemiologist or somebody that's, not, in the lab working with it on a day-to-day basis, can be challenging. And trying to communicate that to, people outside the lab can be a challenge as well. So it's not just affecting us in the lab, but all the stakeholders. Like I said, the epidemiologists, medical examiners that see the reports, as well as the forensic pathologists and law enforcement and so forth. So the nature of what we do is changing. I always like to tell people that the opioid crisis, it really is a real thing. One thing I kind of like to do, it's kind of for entertainment purposes only because it's not exactly like hard data exactly, but I like to look at Google Trends. And so if you look at the search term specifically for opioid crisis, you see that if I can get this highlighter working. Yellow is not a good number or a good color. That's not it. I'm getting there. There we go. So you can see like 2017 is when people were typing in opioid crisis into their Google, search engine. Or we go to the next slide. So in 2010 through 2015 or so, no one's really talking about a crisis at all. That didn't really occur until 2017. And then the last few years, it's really kind of tapered off a bit. So this is kind of like the public perception of the opioid crisis and kind of the timeline of it. But if you were to ask, a forensic chemist or a forensic toxicologist, we started noticing something was up, late 2014 into like 2015. That's when we started noticing things. And a lot of that is because it takes time for what we see in the lab to be conveyed, into the autopsy reports, then the death certificate, and then for the people doing the data mining to, grab that information off the death certificate and tabulate it and put it to a report and get published. It could take, a year or two for, the people pushing that data out to say, hey, we have an opioid crisis. We have a lot more fentanyl deaths. But in the lab, we really do see it in real time. We notice when we're doing more fentanyl confirmations, we can feel that, hey, instead of doing, this once or twice a month, we're now doing it 4 or 5 times a month. That is a flag for us. So that's just another way of saying, if you really want to know what's going on or what the trends are, talk to your friendly, neighborhood toxicologist or forensic chemist. We have a pretty good idea of what's happening, and that's why Allison asked me to be here today. And as an example, a few months ago, she saw a report, I think, coming out of Delaware, I believe, on xylazine. And she asked me, she called me and said, hey, have you ever heard of this? I'm like, yeah, I've heard of it. And I'm showing her right now. On the side of my desk, I have a piece of paper that says xylazine on it with the chemical structure and just a list of cases that I see. So when I see this involved in a case, I'm writing it on this scratch piece of paper, and I can tell her exactly how many I've seen and that, it's on my radar. But you wouldn't know that from just looking at reports and so forth. Again, it takes time to get that pushed out. So call us up. I even use social media like Twitter to figure out what other people are seeing. So I might be like, hey, forensic tox guy, what are you seeing in your lab? I'm, revamping a screen. What drugs do you think I should be thinking about adding to it? And so we all talk with each other. And so if you're an epidemiologist or you're interested in, what's going on right now, again, the toxicologist and the forensic chemists are the ones you'd want to talk to. And then the kind of show, because I know people like real numbers and so forth. This is our rise of heroin in North Carolina. So starting in about 2014, again, we realized, hey, we're doing a lot more heroin cases than we used to be doing. And from about 2010 to 2018, we saw an over 1,000% increase in heroin-related deaths. But it appears to be dropping a little bit for this year. So we don't have all of our 2019 data yet. We're probably maybe like 4 or 5 plus months behind our totals. So we're not going to reach those 2018 levels, I don't believe. So it's going to be dropped off a little bit. And a big thanks to Allison. Whenever I need a fancy graph, she gets it for me very, very quickly. So thank you, Allison. As has been mentioned, we see heroin supplemented with fentanyl and fentanyl analogs, which we call fentalogs, because we try to be cute and fancy. And we saw a huge rise in fentanyl. Again, about 2015, we're thinking, hey, there's something up, and then it just exploded in 2016 and 17, where we saw, again, 1,000% increase in fentanyl-related deaths from 2010 to 2017, and about a 400% increase from 15 to 17. So it was huge for us. And this year, or for 2019, it looks to be dropping just a little bit. So we also had the rise of the fentalogs, and again, our other epidemiologists mentioned this as well. So you can see our heroin cases in blue, fentanyl cases in this kind of peachy color, I guess. What would you call that, Allison?
I did peach.
Peachy. And then in this, I don't know if that's navy blue or black. We'll go with black, of our fentanyl analogs. So most of these fentanyl analogs are new and unscheduled at federal and state levels, and they slowly become controlled substances. But again, it's slow, and it takes a couple years from the time we start seeing something for it to get reported, and then for our legislatures and like people in the DEA to schedule them at the federal level. But really little is known about their activity and toxicity. But they've really dropped off quite a bit. So in 2017, we had 618 total fentanyl analog cases, and that dropped in 2018 and 2019. And 2020 is going to be the same. It's going to drop even more, I suppose. To give you an example of what we were dealing with. So we screened for about 36 different fentanyl analogs in a targeted screen, plus we have another untargeted screen that will pick up kind of everything else. And so we saw huge numbers of like acetylfentanyl and furanylfentanyl and cyclopropylfentanyl. I don't even have all of them listed here. I didn't really have enough room to make it readable. But going into like 2019 and 2020, we're really only seeing about 2 of them. We're seeing acetylfentanyl, where we have a few cases now and then. But even those aren't just acetylfentanyl by themselves. It's usually just a small amount of acetylfentanyl with a larger amount of fentanyl. So like the acetylfentanyl is almost like an impurity in whatever they're using. And then cyclopropylfentanyl still pops up now and then. But this whole smorgasbord of fentanyl analogs has really died down completely. But again, like others have mentioned, you reduce the opioid use either by trying to keep it from coming into the country, like from China, where a lot of these fentanyl and fentanyl analogs are made. Nature abhors a vacuum, and so something has got to take its place. And what's taken its place here has been a huge increase in cocaine and methamphetamine. So our cocaine has increased about 300% since 2010, and about 1,600% in methamphetamine since 2010. So when I first joined OCME in 2010, we only had, I think that's when I started, we only had about 14 cases per year of methamphetamine. I was coming from the West Coast, and all you ever hear about is methamphetamine and ice all over like California and the West Coast. But you come to like North Carolina and like there's no meth problem at all, at least not fatalities attributed to it. So when we started seeing, like 20s and 50s and 100s and 200 cases per year, that's very striking for us. We couldn't ignore that at all. So the next crises outside of the opioid crises that we're seeing are stimulants. We see a ton of gabapentin. Maybe you've heard some of my presentations before on gabapentin and gabapentin used in conjunction with opioids to, as people think it might potentiate the analgesic or the euphoric effects of opioids. And then also designer benzos or benzodiazepines that have never been used in a legal way in the United States, you say by prescription or cleared by the FDA, but maybe were used pharmaceutically, like in Eastern European countries. So if I were to look at kind of like the Google trends of some designer benzos, this kind of mirrors what we're seeing, where we started seeing like flubrorazepam in blue, and the next thing that came along was flubromazolam, and then right now the current benzo of choice seems to be flualprazolam, where we're starting to see more cases. And coming back from an annual meeting, the West Coast, like Orange County, California, they have like hundreds of drivers being under the influence while driving using flualprazolam. So there is obviously some regional differences too, but that's like the next big thing. And after flualprazolam, like, I don't know what it's going to be. I can't predict these things. And this is where I'm handing it over to Allison. Take it away, Allison. And I'll forward slides for her.
So I would like to spend some time focusing on the trends that Dr. Brower has addressed and how they kind of relate to an overall picture of the epidemic of drug overdose deaths in North Carolina. So first, I'd like to briefly explain the terminology that we're using here, and hopefully it will make sense when you see the next slide as well. We're using the term poisoning because it does include all deaths related to toxins such as carbon monoxide, but it's very important to note that the vast majority of these deaths are unintentional drug-related deaths involving opioids, stimulants, benzodiazepines, and some of the other drugs that Dr. Brower mentioned earlier. All right, so this graph shows the number of confirmed poisoning deaths in North Carolina by year, including our 2019 provisional data, which is represented as a dotted line. It is important to note that this dotted line appears to be decreasing because we have many pending cases at this time, so we don't quite have a complete picture for 2019 yet. In terms of 2019, though, you can see that we had a higher number of poisoning deaths in the first quarter compared to that same time frame in 2018. The other important thing to note about this graph is that 2017 represents the highest number of confirmed poisoning deaths in North Carolina's history, and I've included 2016 for additional context so that you can see that the increase from 2016 to 2017 was truly significant. In fact, the total number of poisoning deaths increased by approximately 24% in a single year. So while we have reason to be hopeful that this number of poisoning deaths or overdose-related deaths is stabilizing or even decreasing, this graph shows that the number of autopsies performed in 2019 actually increased by approximately 4% compared to 2018. In essence, we may not have a complete picture for 2019 yet in terms of confirmed poisoning deaths, but this graph provides a great provisional picture of what's happening in North Carolina and how many deaths are being investigated as suspected drug overdose deaths. In 2019, approximately 58 to 60% of all autopsies performed were performed to rule out overdose, which is represented by the dotted line here. I've also included confirmed poisoning deaths and then confirmed opioid-related poisonings as a subset to show that we're actually pretty good at predicting which deaths will be confirmed as poisonings once the entire investigation process is complete. So as you can see, the dotted line, which reflects the number of autopsies that we're performing to rule out overdose, very closely aligns with that solid black line, which represents confirmed poisoning. at least until we start to notice that it drops due to the number of pending cases that we still have at this time. This graph also shows again that 2017 represented the peak of the current crisis in North Carolina, but we still have a long way to go, and there are some emerging trends that we're keeping an eye on moving forward as public health practitioners. And the last thing I want to say is, of course, feel free to send me an email if you'd like to request any data, including updates on 2019 data as we move forward. You can find my contact information and Dr. Brower's on the last slide, and of course, our slides will be available as well. So I'll go ahead and stop here, which hopefully leaves plenty of time for the group to answer questions, and thanks so much for your time.
Thank you.
All right, thank you, Allison and Dr. Brower. I will take over control one last time, and then we'll jump right into our Q&A session as we have had a few questions that have come in. So for the first question, I'm going to put this one back to Rosie. This came in during your presentation. How did the data analysis account for changes in testing, whether changes to the overall testing scheme or limits of detection or reporting for fentanyl or other compounds? Then say this may not be relevant if testing considerations did not change from 2007 to 2018.
So I'm assuming that this is probably around kind of when all these new fentanyl analogs were being introduced, and we didn't really have or our tox lab didn't really have the reference standard to identify, and I don't think they even quantified the analogs. I know that for those specifically, we were having the issue where we were having like known drug overdose or highly suspected drug overdoses, and we were doing tox testing, and they were coming back with nothing. So we had to actually outsource some of our cases to NMS labs because they had an earlier detection for various fentanyl analogs. So we did that for several months, if not a year or so. And so we really didn't have any changes, but it was trying to get our state tox lab up, up to standard with what was going on with all the introduction of the fentanyl analogs. So it really wasn't a change in the data analysis. It was just we reported on what was found and aired on the caution that there's potentially more analogs here, but we don't have the ability to identify them.
All right. Next question came in during Dr. Brower and Allison, your presentation, but really it's one that can be answered by the group. So I'll pose to you first. Michelle was looking for a recent and exhaustive categorized list of substances involved with death. Do you have any resources or any direction that she could go to find something like that?
Sure. So this is Allison. I can absolutely provide a list of substances that we've detected in our decedent population, and of course, Dr. Brower is a great resource for that information as well.
I would get the list from Allison because
she would vet it, to be clear.
All right, perfect. So Michelle, just make sure that you, when we are finished with today's event, you do navigate back to the main page. There you will find a PDF version of all of today's presentations, and Allison and Dr. Brower both had their contact information in the end of their presentation, so you'll be able to find that there. So another question, again, this can be one that's posed to the entire group. An issue that this user is struggling with is that there seems to be many different ways to categorize substances. She's wondering if there is a consensus around how to best categorize information so that it makes sense to a wider audience of reader from the health, public administration, and law enforcement sectors.
I guess you mean like categorize in terms of drug class? Is that how you would interpret that?
That's kind of what it seems, and you can kind of go with that. If the user wants any more information, they can definitely elaborate on their question.
Sure. So this is Allison again. I can weigh in a little bit and say that I find it can be helpful not just to categorize drugs by fentanyl or fentanyl analog, but also to help audiences understand which are illicit and which are prescription. That can be very helpful in making sure that a report or any kind of publication is sort of easily understood by the general public. But I'll also defer to Rosie and Sarah, as they may have some great feedback on that question as well.
This is Rosie. I would agree with that, and I think that prescription and illicit is a big thing to really separate. I also suggest if reaching out to your tox lab, or if you have a drug seizure lab, to get a list of the things that were identified, and if they have some kind of manual for the class of drugs, because the ones we really report on are prescription opioids, benzodiazepines, stimulants, and kind of group those, but like stimulants, you can have, methamphetamine, cocaine, but you can also have like prescription stimulants. So, I suggest reaching out to your lab to maybe get some clarification.
And this is Sarah. I agree. We struggle with that when we have medical students come in and they're asking us how best to categorize all of these. And it really depends on the audience and what we need, because sometimes we do a very broad classification, prescription versus illicit, and then Rosie was saying, the stimulants, and very broadly. And then other times, depending on the audience, we may go much more specific and work with our toxicologists on that.
All right. So the next question we had come in is really, again, for the entire panel, but Dr. Lathrop, will put it to you first. Can you speak to the importance of communication between tox labs, both within the state and also between states?
Oh, that's a great question. What I have found, my experience has been that there's not a lot of communication between the state lab and the out-of-state lab that we use. I think it could be very helpful. I say that just from the medical examiner's point of view. I think on the listservs that they use, they are very much sharing with each other the information. I've been very happy with NMS labs as far as keeping us apprised of what they're testing for and what they're seeing emerge. And I actually met one of their toxicologists, and I was astounded by how deep he went into the information, and he was staying up to date minute to minute with new information that was coming out. So I think as toxicologists, and our other presenter can speak better to that, but it seems like they were sharing a lot of information, toxicologist to toxicologist, just because there's such a flood of new information arising every day as far as what's out there.
I mean, from a toxicologist viewpoint, I think it's important for tox labs to communicate. We don't have to exist on our own little island, when we have such great resources and colleagues in fantastic labs throughout the United States and the world. And it's really easy to communicate with people now. Like I mentioned, just being able to go on social media or Twitter and just say, hey, what are y'all seeing out there? And, you can get a flood of responses, which is very helpful. But also, within your state, it's helpful to communicate with drug labs. So like our lab here at OCME, we're in no way affiliated with the state crime lab, but they're the ones who get the physical evidence and the drug seizures and so forth. So knowing what their drug chemists are pulling off the street directly is kind of like a snapshot of what we will be seeing in our cases. So trying to have that line of communication open is very important.
And this is Rosie from Virginia. I just want to say that our tox lab, I know that they push all their information to the national lab, which is NIFLIS, NFLIS, and that's for the DEA, so they can share information about identification of stuff, new substances, what's being found, and I think that that's a useful resource.
All right, next question we have coming back to you again, Dr. Lathrop. Thank you very much to all of our presenters for their interesting and informative presentations, but this attendee is asking, they were wondering if we could hear which pharmaceutical opioids were the top contributors to opioid deaths in New Mexico.
Sure, it's oxycodone. We don't see quite the level of fentanyl and fentanyl analogs that other jurisdictions have seen, but here it's oxycodone, and then again, reverting to heroin as well. We continue to have challenges with just basic heroin here as well, but oxycodone for the pharmaceuticals.
All right, we're going to give everyone just another couple of minutes to pose any questions that they might have of our subject matter experts. While we're waiting on those questions to come in, again, just want to remind you that we do have a PDF version of all three of today's presentations that is, again, located back on the main page where you logged into today's event. Also, we are recording today's event, and we will be converting it into our archival version over the next few days. Should you want to refer back to the material at any time, or if you have any colleagues that might have missed today's live event, they will be able to view the archival recording as well. Again, we are going to give everyone just a couple of minutes, but before we do wrap up today, I'm going to give the speakers just one final minute to close out before we do close today's webinar. So Dr. Lathrop, if you have any closing words for us.
Oh, thanks again. I have to say I really enjoyed hearing the other presentations. It's a bit comforting to know that we're not alone in what we're facing and to see these trends repeated in two other jurisdictions. But really, like I said, even if you feel like your office doesn't have enough resources, there are folks out there that can help you with this type of analysis so that you really understand what's going on. I think it's so important to be able to put that data together in aggregate form and move beyond just looking at the individual cases so that you can really help your communities and your jurisdiction understand the problem it's facing and begin to creatively think about possible solutions. And again, the key to that really is collaborating with other agencies so that they're taking advantage of your amazing data and skill sets, and you can take advantage of some of their skill sets too.
All right, thank you, Dr. Lathrop. We'll turn the microphone over to Rosie Hoprin.
I want to say thanks for having me today. It's nice to hear from everybody, and it's very interesting to hear how we all have the same objective of what to do, but kind of a little bit of different things about getting to that objective. So thanks for having me.
And our last presenters today, Ms. Allison Miller and Dr. Justin Brower.
Go ahead.
So again, I'd also like to thank everybody for listening in, and I really appreciated hearing stories from New Mexico and Virginia, and I would also echo the importance of collaborative partnerships like others have mentioned on the line today. So with that, I'll let Dr. Brower take over.
What Allison said, I always like hearing from other states and what they're seeing and experiencing, and I don't have a whole lot of communication with epidemiologists because I'm stuck in an office in a lab all day, so thank you for letting me muddy up your waters.
All right, we did have two follow-up questions that came in. Dr. Brower, you had mentioned Google Trends in the later part of your presentation. Michelle is asking, how are Google Trends used to monitor new psychoactive substances?
I don't know if it's really used to monitor so much. I just like to try to use it as a tool to kind of get an idea of what's out there. So if you were to say Google, like all, in one search of like say new or novel psychoactive substances, you get a feel for like the timeline or the history of people putting these Google searches. But also in Google Trends, they will show you other related searches that people have used or maybe used right before or after that type of search. And so it might not be new psychoactive substance, but related searches, it'll show you might be some very specific compound or a specific compound on Reddit or some other drug form to kind of give you an idea of something specific that might be out there. So again, it's just a tool to use that I find helpful from time to time.
All right, and the last question we have of the day is can go to the entire panel. Does anyone have any experience in a county-based coroner or medical examiner system and can speak to the differences in data collection?
I don't, from North Carolina.
Yeah, New Mexico, I don't either. I've only worked with New Mexico.
I don't have experience either, but I've heard that it can be difficult because with a statewide system, ideally, each region or region of the state or part or a district that covers part of the state kind of does the same thing. So if you die in one locality, you're going to get the same process as another locality within the statewide system. So I would assume that it might be a little bit more difficult when you're dealing with the county-based system where your next county over might be doing things a little bit different. But I don't have any direct experience.
Hi there, this is Allison. I'll chime in very quickly and say that much like kind of what Rosie had to say, North Carolina, our office here in Raleigh does provide oversight for the entire statewide system, but we have regional autopsy centers that are contracted and they have varying resources themselves. So sometimes there might be a delay in an autopsy report coming to our office and being processed by our case management. So that can create some time lags and also lead to maybe some turnaround time issues if we're not able to get the information we need from our regional autopsy centers or elsewhere in the state just to certify the death and finalize it. So I guess in that sense, data collection can be somewhat of a challenge, but it's, we're fortunate enough to have great regional autopsy centers here who are committed to doing the best work they can despite sort of strapped resources.
All right, thank you all so much. And with that, we are going to go ahead and close up today's webinar. Obviously, the first thing we would like to do is to thank all of our presenters and subject matter experts for today, for giving their presentation and taking time out of their days to be here with us. So thank you so much, Dr. Sarah Lathrop, Rosie Hobron, Allison Miller, and Dr. Justin Brower for your presentations. Obviously, we would also like to thank all of our attendees for joining us today. These webinars are simply not possible without your attendance and your support. As we ask with all of our webinars, before you leave today, we do ask that you participate in our short survey. You'll find that directly below the closed captions on the bottom right. So simply click the word survey. It will open up a new window for you. So if you could take a few moments to go through that, we always want to make sure that we are providing you the best webinar experience possible, as well as adjusting the content or the way that we disseminate that information out to you, our audience. So if you could take a few moments to complete that, we would definitely greatly appreciate it. As we've mentioned a few times, we do have PDF versions of all of today's presentations back on the main page, and we also recorded today's event and we'll be converting it into our archival version over the next few days. You will also see in the chat pod momentarily, Tyler will be posting links to all of our social media outlets, LinkedIn, Facebook, and Twitter, as well as links to our podcast, which is now coming up on the 8th season, and links to our website where you'll find all of our no-cost webinars, events, success stories, and reports that we are constantly putting out through the Forensic Technology Center of Excellence. Again, thank you everyone for joining us for today's webinar, and we look forward to seeing you in our next event. We hope you have a great rest of your afternoon.